Hello, good evening. Today our discussion will be about skin lesions, eMRCS MCQ. It is a short discussion today, and hope you all share with us with questions and answers. Okay, so today we are going to discuss skin lesions. I don't know if someone has any experience or have studied before any about this, or just first time. Okay, so before I start, I just want to give some small points or some short points about what we are going to see in some skin lesions and the key points in every one of them. Okay, we have just a minute. Okay, we have what is called seborrheic keratosis. Okay.
Yes.
This, in our scenario, you will find two key points. By the way, most of them will be an old patient. You'll find greasy or seborrheic lesion plus keratin. So from its name, it will be seborrheic keratosis or seborrheic keratitis. Okay?
Yes.
The other one is most common in the exam. We found what is called keratoacanthoma. Keratoacanthoma, by the way, it is a lesion, happens sometimes mostly in the face, that mimics squamous cell carcinoma. Okay, and maybe clinically sometimes different to distinguish between squamous cell carcinoma and keratoacanthoma. But the history in the scenario, you will have a short history within few weeks or months. That is a rapid growing skin lesion, okay, with keratin and rapid resolve with scarring. So rapid growth plus keratin followed by rapid resolve plus scarring. Okay, sometimes tell you friable, large friable keratin, large friable keratin. Okay, and this is keratoacanthoma. This is the key point in it: rapid growth, rapid resolve with scarring. The third most common, what is called seborrheic warts. Seborrheic warts. Seborrheic warts happen in old people, maybe 70 to 80, appeared on the trunk. I think many of us have seen this. Pigmented seborrheic lesions. Okay, multiple seborrheic pigmented on the trunk. Okay, this is seborrheic warts. What's the treatment is? Because you're asking about the treatment. Shaving, just shaving. okay? Or shaving by cautery or shaving by cryotherapy or something like that. But this is the trick. No excisional biopsy, no incisional, no punch, no excisional safety margin, nothing of this. Okay. Next most common lesion, we'll see it, is basal cell carcinoma, purely white. This is the pathognomonic, and you'll find it even in recalls, purely white lesion, face, around slowly growing. So it will be basal cell carcinoma. Okay, treatment is excisional biopsy. It is removed with safety margin about 0.5. So this is basal cell carcinoma. The other thing is squamous cell carcinoma, and this is chronic irritation. And I think on top of ulcer or de novo, with the characteristic is scaly, resistant lesion or ulcer for a long time, sometimes necrotic floor, sometimes reverted edges. So it is squamous cell carcinoma, and also by excisional biopsy. And after the biopsy, we decide the definite treatment if we need more excision. Okay, the other lesion is Pioderma Gangrenosin, and this is a lesion associated with inflammatory bowel disease or mainly Crohn's disease. So any skin lesions appear with Crohn's disease or near the Crohn's disease or near the opening of ileostomy of Crohn's disease or in the stump itself of Crohn's disease. As he mentioned, Crohn's disease, so it is Pioderma Gangrenosin. The other one is Dermato Fibroma, and this is a painful or a little painful, not so much, raised, firm nodule, mostly on the thigh, and preceded by trauma, like a pinprick or something like this, or insect bite. You know the picture of insect bite? This is the same of dermatofibroma, and it's the lesion when you feel it appears smaller than you feel it, it's larger subcutaneous, and sometimes it's painful or just give some pain. And this is characteristic of dermatofibroma. He will tell you that is a site of previous trauma or insect bite. So it is dermatofibroma. Okay.
Yes.
That's what I can remember about most skin lesions you'll find in your exam. Okay, so we'll go through the questions, and through the question we may find new. So we'll start with Dr. Dafir, followed by Dr. Nuran, Dr. Abu Yazid. You arrived safe?
Yes, finally.
Okay, so Dr. Dafir, Dr. Nuran, Dr. Abu Yazid, and so on. Okay?
Okay.
Let's start. Okay, Dr. Dafir.
70-year-old lady presented with a number of the skin lesion that describe unsightly. On examination, she has a number of the raised lesion with a gray surface located over the trunk, apart from having a grassy surface. The lesion also seemed to have a scattered keratin plaque located within them. What is the most likely diagnosis? Keratocanthoma, pilocyst, dermatofibrosis, seborrheic keratosis, and epidermoid cyst. So it's seborrheic keratomatosis.
You say seborrheic
Yeah.
keratosis. As we said, the lesion has both greasy surface and scattered keratin plugs, so it's seborrheic keratosis. I think it's easy.
Yes.
Okay. Next question, Dr. Nuran.
A 72-year-old man presents with a large nodule on his face. It's friable. There's no regional lymphadenopathy. He is lost to follow-up and reattends several months later. This occasion, the lesion has been noted to resolve with scarring. What is the most likely lesion? A. Pyogenic granuloma. B. Keratoacanthoma. C. Melanoma. D. Basal cell carcinoma. E. Dermatitis artifacta. Large nodule on face, lost to follow-up, resolve with scarring. We said what resolves with scarring is keratoacanthoma, B.
Perfect. Exactly. Keratoacanthoma, rapidly growing, and then friable keratin, then rapid resolve with scarring. That is keratoacanthoma. Okay. Next question, Dr. Abu Yazid.
22-year-old woman present with newly pigmented lesion on her right chin. It has regular border and normal appearing dermal appendages. However, she reports a recent increase in size. What's the best course of action? Pigmented lesion, here's now. Excision biopsy.
Any answer?
A. Excision biopsy.
Yes. No. Yes, excisional biopsy, exactly. So this is lesion with regular borders in a young woman with normal appearance of dermal appendages, so nothing in the scenarios that gives you this is some malignant or some atypia, but started to increase in size. What is the course of action? Okay, you do an excisional biopsy. Excisional biopsy normally take about 1 to 2 millimeter, about 1 millimeter around the wound. Okay, this is the normal. Any lesion, as you don't know what is the lesion exactly, except you did punch biopsy or the lesion is highly suspicious, so you are not allowed to take a safety margin, especially in the face. Okay, so you are not allowed to take from the face with safety margin unless you're sure this is something bad or something malignant by punch biopsy or maybe incisional biopsy from big lesion. So you just do an excisional biopsy and then do the histopathology followed by reoperation. If you found something bad or unclear margins, you will go for more excisional biopsy by Mohs microsurgery or frozen section. Okay, but shift biopsy is not allowed here. Incisional biopsy in a small lesion also not allowed. Excision with safety margin completely contraindicated, and excisional biopsy is the best answer. Okay, next question, Dr. Daffer.
Which is the skin lesion listed below are the most likely to be resemble a malignant melanoma? Pots nevi, Dermato Fibroma, the fibroma, squamous cell carcinoma, Bowen's disease, Shibori quart. It is A. Spitz nevi.
Spitz nevus, yes, exactly. It resembles a malignant melanoma. Okay, and it's better to Cyst and for histopathology.
Yeah.
So just know it by name. It's something, it is the only question about Spitz nevus, that is resembles malignant melanoma. No other question about this type of nevus. So just a unique question. Next question, Dr. Nuran.
A 72-year-old man is investigated for weight loss. On examination, he is deeply jaundiced and cachectic. He also has a dark velvety lesion coating his tongue. What's the most likely diagnosis? A. Acanthosis nigricans. B. Mycosis fungoides. C. Bullous pemphigoid. D. Squamous cell carcinoma. E. Bacterial infection. Jaundiced, cachectic, velvety lesion. I think it might be Mycosis fungoides.
Because this is old man, weight loss, and jaundice and cachexia. So it is something like cancer. Okay. So we are talking about cancerous lesion or paracancerous lesion. Okay. The dark velvety or pigmented velvet lesion that appear on tongue, sometimes appear on the body, especially on the axilla or some skin creases in the neck. This is what's called acanthosis nigricans. Acanthosis nigricans. And one of the para-malignant syndrome lesions of GIT lesions. Very common with the skin, with the stomach, duodenal, and pancreatic and hepatic cancer. It's very common acanthosis nigricans. Sorry?
Doesn't acanthosis nigricans also at diabetics? Acanthosis nigricans also in diabetics at the back of the neck? Is that right?
Sometimes acanthosis nigricans is a dark velvety lesion that appear on the skin, or sometimes here in the scenario on the tongue. And this is one of the manifestations and one of the lesions you will search in your abdominal examination station in part B. Inshallah, when you go for part B, when you are looking for general examination of the body, before you go for local examination of the abdomen, you will look in the skin and let the patient raise his arms to look at the axilla, because acanthosis nigricans are very common at the axilla, like skin, velvety, pigmented lesions, what's called acanthosis nigricans. And it's a very common question, by the way, even with, I think I did see it in one recall, that associated with cancer stomach or cancer GIT. Okay?
An 83 years old lady present with multiple patches of pigmented irregular, superficial lesion over the torso. They don't bleed, but have become increasingly itching. What's the best course of action?
What's your diagnosis?
I don't know.
Okay, so how you know the Seborrheic warts? Okay. This is seborrheic
Okay, so
warts.
it's
What
shaving.
happened, you find, by the way, you find it in many, maybe you can't find it in dark skin people, but in white skin people you found aged over 80, like round, dark or sometimes light brown lesions all over the skin. This is multiple patches, sometimes pigmented and irregular in shape, and scattered all over the skin of the torso.
Okay.
Sometimes it's itchy, so it is called seborrheic warts. What's your treatment?
Shape biopsy. A.
Exactly. Shape biopsy is the treatment of seborrheic warts. Okay.
Okay.
This is an old age, so you're not going for excisional or true cut or something. You're just shaving the most itchy lesions of these multiple lesions. Next question, Dr. Duffer.
Patient with the chronic disease has a purple colored skin lesion near the ileostomy site. What is the most likely diagnosis? Pioderma Gangrenosin, pemphigus vulgaris, metastasis, chronic disease, dermatitis, herpetiform, bullous pigmento, perfigoid. I choose 1A, Pioderma Gangrenosin.
Okay.
Which is what they call
Skin lesion associated with inflammatory bowel disease, especially Crohn's disease. It will be one of the extraintestinal manifestations of inflammatory bowel disease, which is Pioderma Gangrenosin. Okay. Next question, Dr. Nuran.
A 58-year-old lady presents with changes that are suspicious of lichen sclerosis of the perineum. What is the best course of action? A. Wide excision of the area and split thickness skin grafts. B. Punch biopsy. C. Excision of area with 0.5 margin. D. Excision of the area and full thickness skin grafts. E. Excision of the area with 2 centimeter margin. Lichen sclerosis of the perineum. B. Punch biopsy.
Yes,
I don't know.
exactly. Yes, no. Yes, punch biopsy. Okay, this is a lesion. I don't know what is. What is lichen sclerosis is not a cancer. So excision with safety margin and number C and number E is wrong. Excision of the area with full thickness skin graft. No, I don't make full thickness skin graft in the perineum. Wide excision of the area with split thickness graft is the same idea. I'm not just excisioning and doing a graft in the perineum. To punch biopsy to confirm my diagnosis, and it's the right answer. Also, one of the unique questions, lichen sclerosis of the perineum, punch biopsy, and I didn't see it in the last 2 years recalls before. Yeah, 2019, 2018, and I think also 2017, I didn't see this question before. Just put in our mind. Okay, next question.
22-year-old man present with infected sebaceous cyst. Cystic cells are swollen, discharging pus, and has some surrounding erythema. What's the most appropriate treatment?
Okay, what's your treatment without reading?
just drain.
Sorry?
Just drain the abscess.
Just drain. Yes, this is an abscess. Sebaceous cyst infected is converted to sebaceous abscess. And so it's incision and drainage. Okay, so what's your answer? Search for
C.
it. C, incision with excision of the cyst and packing, yes. So C and D is incision, but in D will be conservation of the cyst, and this is not logic. Exactly, we just open and the drainage, and we making a curette of the cyst, cysticle, If it is highly infected, we like cure it, and then put a pack with loaded with antibiotic or with betadine or something like this. And this is the treatment of infected sebaceous cyst. What is the other name of sebaceous cyst?
Epidermal cyst?
No. Sebaceous cyst is a cyst related to hair,
Yes.
skin
hair. So it is called a pillar cyst. Pillar cyst, okay? Because we have a question, we'll ask about a pillar cyst. So, okay, next question, Dr. Dafir.
A 21 years old lady presented with a nodule on the posterior aspect of her right calf. It has been presented at the site for the past six months, found accurately at the site of the previous insect bite. Although the nodule appear small on the palpation, it appears to be nearly twice the size appearance of examination. Overlying skin is fainting pigmented. What is the most likely diagnosis? Pillar cyst, Dermato Fibroma. It is correct. The Spitz nevus and seborrheic wart and basal cell carcinoma. So I choose B.
Okay, so a skin lesion, firm, young lady, in a previous insect bite. By the way, in the recalls even comes in a site of previous insect bite or a site of a previous minimal trauma, right? Trivial trauma like pinprick or any flower prick, something like this. So it happens what's called Dermato Fibroma. Sometimes it's a little bit tender. Okay. I think the key point, the key word here is insect, previous insect bite.
Okay.
Okay, next question, Dr. Nuran.
A 65-year-old man presents with a 5-centimeter ulcerated area over his medial malleolus. It has been present for many years, and the nurses have complained that it is not healing with simple bandages. What is the best course of action? A. Perform a core biopsy. B. Perform a punch biopsy. C. Arrange a split thickness skin graft. D. Undertake an incisional biopsy. Or E. Arrange for wide surgical excision and skin grafting. I would have said it's a venous ulcer, and so if bandages do not work,
You are lucky with biopsy, Dr. Nuran.
Hmm?
You are lucky with biopsies.
Yeah. Well,
So what do you suspect here? This is an old age patient with 5-year ulcer on the medial malleolus.
Patient may have caused squamous cell carcinoma.
Exactly.
And so, okay, a punch biopsy, so we can later on, or
Exactly.
excision. Okay,
No,
punch biopsy.
punch biopsy. Yes, yes. It is a 5-centimeter ulcer, so it is a big ulcer. I can't do excisional biopsy for it. Incisional biopsy we don't put for ulcer because we sometimes take some incisionals from more large ulcers, take incisional biopsy from the edge and take healthy tissue with unhealthy tissue. But here with chronic ulcer, we used to take punch biopsy, and with the after diagnosis, we can decide what operation we'll do for the patient. Okay, so right, it is a punch biopsy. Okay.
Yeah.
Next question.
68-year-old farmer present with skin lesion on his forehead. It has been present for past 6 months and has grown slightly in size during that time. On examination, he has an ulcerated lesion with barely white raised edge that measures 2 centimeters in diameter. What is the most likely diagnosis? Okay, white basal cell carcinoma. D.
Exactly.
Mhm.
Purely white, go direct, run for the basal cell carcinoma. This is a pathognomonic, and it is the pathognomonic for eMRCS to get a question. Purely white, so it is basal cell carcinoma. You have no other lesion in any branch with purely white. Purely white raised edge on the face, slowly growing over 2 years or something like this, or 6 months. So it is basal cell carcinoma. Okay.
Okay.
Purely white. In recalls all questions of basal cell carcinoma, purely white lesion. Okay. Central ulceration sometimes, necrotic floor sometimes, everted edge with purely white, sometimes with surrounding telangiectasia, purely white also. This is all basal cell carcinoma. Okay. Yeah. Next question.
A 28-year-old man undergo an ileocecal resection and end ileostomy for Crohn's disease. 1 year
Okay,
later.
answer.
Pioderma Gangrenosin.
Okay, yeah. It's a scan. You want to continue the question? No problem. Okay.
No.
1 year later.
The same. The last one I read it.
Yes. So it is 1 year later. The patient presents with deep painful ulcer at his stoma site.
Yes.
So like a metastatic Crohn's disease.
Yes.
So Crohn's disease with ileostomy with a skin lesion or painful ulcer. It is Pioderma Gangrenosin, one of the extra intestinal manifestation of inflammatory bowel disease, especially Crohn's disease. Crohn's disease is more associated with extra inflammatory, with extra intestinal manifestation than ulcerative colitis, by the way. Okay. Next question to Nuran.
A 30-year-old man cuts the corner of his lip whilst shaving. Over the next few days, a large purplish lesion appears at the site which bleeds on contact. What's the most likely diagnosis? A. Pyogenic granuloma, B. keratoacanthoma, C. Melanoma, D. squamous cell carcinoma, or E. Adenocarcinoma. Corner of his lip, trauma. No. I want to say squamous cell carcinoma, but squamous cell carcinoma.
With the age, with this age?
A very
next in few days after he shaved, after he cut his lip with shaving, so all of us have squamous cell carcinoma. Oh my God. All of us have squamous cell carcinoma. Okay, this is a new question and you don't know the answer. Someone shaving and make a wound and he didn't suture this wound. After a few days, trauma. Yes, exactly. And after a few days, some bleeding tissue or bleeding purplish lesion. Is it adenocarcinoma?
No, I was just thinking that the lip, the lower lip, it's always squamous cell carcinoma, so that's why.
What's your specialty, Dr. Nuran?
Neurosurgery.
Neurosurgery. Okay, if you found someone have some wound in his body and he didn't suture it, and after, especially in the hand or something like this, and comes to you after 2 days and he tell you, I didn't like to have sutures and something. What will you see?
Yeah. I guess your point.
What will you see? Yes, you'll find a granuloma infected, or sometimes it's a normal granuloma and sometimes infected. And very common we see the granuloma in the umbilical stump in babies after falling down of the umbilicus. You find a small reddish, easily bleeding skin or tissue mass. It is granuloma. So it is not a keratoacanthoma. We call what is keratoacanthoma lesion in old age, and it is friable and resolved spontaneously with scarring. It is not melanoma. No melanoma will happen on the lip after a few days. No squamous cell carcinoma or adenocarcinoma will happen in the lip after a few days. Okay, so it is pyogenic granuloma. any recent wound in a young patient may happen a pyogenic granuloma if he didn't care about it. Okay.
Yeah.
Okay. Next
Clear.
question. Clear. Okay.
Which of the following statements?
Dr. Bolizi, تفضل, sorry.
Which of the following statements relating to sebaceous cyst is false? When infected and ulcerated are also known as cook-bicular tumor, typical contain pus, usually associated with central punctum, most common occur in the scalp, they will typically have a cyst wall. Contain pus, not contain pus B. Sebum.
Okay. Exactly. It's typically it is not containing pus. It's containing sebum, but when infected, the sebum start to collect pus. So, Cox peculiar tumor, I did see once in one recall, I think. So this is the other name of sometimes when infected or ulcerated, it will named Cox peculiar tumor, or sometimes get it. The reverse gives what is Cox peculiar tumor. It is sebaceous cyst, infected and ulcerated. Okay, it's like, I did see it before. It's like a plate in the skin with undermining edge and a sebum. I did see maybe 2-3 times in my life. So it is really weird. You'll find like this is the skin, and this is a plate open, and this is the cyst, and the sebum like this from it. And the patient like afraid from this, and just you squeeze the skin, all this will be empty. See this Cox peculiar tumor. Okay.
Okay.
Okay. So this is typically contains pus. This is the false answer. Next question.
Which of the following statements related to the keloid scar is untrue? They have a prediction for the sternum, mandibular, and deltoid area and wound. They are confined to the margin. Okay, this be confined to the margin of the original injury. They are of recur after excision, may be occur even after the superficial injury. They may be treated by the injection of the triamcinolone. So it's B. They are confined to the margin. So it is about exceed the margin.
Exactly. This is the only thing you are asked about a keloid scar and a normal scar. This is the only question asking about, and he just wants you to know the difference between normal skin scar and the keloid scar. The keloid extends beyond the margin of the original wound or the original injury. This is the only thing he wants you to know the difference. Hypertrophy scar and keloid scar. Okay, no other question about this he wants to know again. This is a keloid scar. This is maybe a small wound, and this is started to be beyond the normal, and this is very common in extremities and on the chest wall. The very common site of extension or. The next question. Dr. Biopsy, Dr. Nuran. Do you want to change? Do you want to pass this question for one of your friends? I think.
Yes.
Yes? Okay.
Yeah.
Dr. Yazid, معلش, take this biopsy,
Okay.
please. And she will go for the next one.
73-year-old man. Present with 1.5 centimeter ulcerated basal carcinoma on his back. What's the best course of action? Excision with 2 cm margin. B.
Basal cell carcinoma. No. 2 cm margin. Very big 2 cm margin.
Hi.
0.5 cm margin. A.
Oh, from 0.3 to 0.5, according to any Basal cell carcinoma lesion less than 2 centimeters according to the Royal College and the UK policy. Less than 2 centimeters, you will go for 0.3 to 0.5 safety margin only. Okay, so 2 centimeter margin needs a very big lesion to find 2 centimeter margin. Okay, even I did read some squamous, I think in one recalls, or we have just question part B about squamous cell carcinoma and asked about the safety margin. It was also 0.5, by the way, as I remember.
So melanoma is just according to the size?
Yes.
Melanoma according to Breslow thickness.
Yes.
Melanoma according to Breslow thickness. We will talk about it soon. I think we passed one, and if we don't, just I'll tell you Breslow thickness. We'll ask about it. Okay.
Okay.
Ah, yes. Here. Margins of excision related to Breslow thickness. If less than 1 millimeter, you'll take 1 centimeter. If the lesion is from 1 to 2, you will go from 1 to 2, from 2 to 4 to 3, and more than 4 milli, maximum is 3 centimeter. This is the documented and known skin margins for melanoma. Okay.
Okay.
Okay, he will not ask you about this. I think mostly he will give you a lesion with 0.8, something like this, less than 1 millimeter, and you will choose 1 centimeter. More details he will not give you. But the most common question about Breslow thickness is, what is the most prognostic factor for malignant melanoma? This is the most frequent, almost in every exam. What is the most prognostic factor for malignant melanoma? Is Breslow thickness. The less the thickness, the good, the better, and the good the prognosis. Okay.
Okay.
We found it in recalls, inshallah. More common than the scan lesion or the size of the margin, safety margin. The other question is much more common, even in every exam. Okay, so next question, Dr. Nuran.
A 53-year-old man presents with a nodule on his chin. He is concerned because it has grown extremely rapidly over the course of the preceding week. On examination, he has a swollen red dome-shaped lesion with a central defect that contains a keratinous type material. What's the most likely cause? A. Actinic keratosis, B. Bowen's disease, C. Pyogenic granuloma, D. keratoacanthoma, or E. squamous cell carcinoma. Growing rapidly, swollen, red, dome-shaped, central defect, keratinous. I'm a bit confused between actinic keratosis and keratoacanthoma. A keratoacanthoma, rapid growth. It's keratoacanthoma. May I ask, is actinic keratosis related to a certain type of trauma, plant or something like that? I emptied my bag yesterday. Actually, everything was there.
Sorry, Dr. Doffer. Okay.
No, sorry.
Sorry, just read this question because here, just I couldn't catch the photo. I take the screenshots fast, so I couldn't catch the photo. So we have to read it like this. It depends on the photo. By the way, this is a very common question in the exam.
A 72-year-old man presented with a lesion in his back. It appears as shown below. It is a basal cell carcinoma. Okay, melanotic malignant melanoma, squamous cell carcinoma, Merkel cells.
Yes, exactly. This is a picture of pearly white. This is a picture of pearly white.
Yes.
Okay. This is a very common question in MD, in part A, in part B, even in part B, when ask you and give you a picture during your gestation, he will give you this picture. This is the most common picture about about basal cell carcinoma, pearly white, and this is before ulceration and surrounded sometimes with telangiectasia because of inflamed blood vessel and lymphatic vessels, lymphangitis and vasculitis around the lesion. Okay, take another question, Dr. Duffer. Next one.
Yes. A 29 years old man presented with a lump in his scalp is located approximately 4 centimeters superior, just a minute, just superior to the external occipital protuberance. It feels smoothly and slightly fluctuated and has a currently located small epithelial defect. What is the most likely diagnosis? Cox bacular tumor, dermoid cyst, sebaceous cyst, Merkel cell tumor, required. It is dermoid cyst.
The scalp, 4 centimeters superior to the external occipital protuberance. It is smooth, slightly flaculent, and has a centrally located small epithelial defect. What is this epithelial defect?
Seborrheic. Sebaceous cyst.
What is this? Exactly. What is the small epithelial defect? This is a punctum. Yes, exactly, Dr. Nuran. Perfect. This is a punctum of the sebaceous cyst. Okay, this is a punctum of sebaceous cyst. So sebaceous cyst is very pathognomonic. By the way, the punctum is pathognomonic for sebaceous cyst, and it is eccentric and dark in color sometimes, or sometimes just epithelial deficit or defect. Eccentric, it is not centric. Okay, so this is the sebaceous cyst of the scalp, very common in the scalp. Okay, next question.
28-year-old female, present with small nodule located in back on her neck, is excised for cosmetic reason, and the histology report states that the lesion consists of sepum-filled lesion surrounded by outer root sheath of hair follicle. What's the most likely cause? A. Pillar cyst.
Exactly, this is sebaceous cyst or pillar cyst. I don't know why they care about sebaceous cyst. It takes a very big issue in UK about this one. We have about 5 questions about sebaceous cyst now. I hope in exam all question will be sebaceous cyst. Okay, so sometimes this is a pathology of sebaceous cyst or pillar cyst. Here in the question, he wants to tell you the pillar cyst is the right name or the best name for correct name for sebaceous cyst, because it is a cyst related to the hair, not related to the sebum. Okay. Dr. Nuran, it is not a biopsy, thanks. Go.
A 34-year-old gardener presents with a lesion affecting the dorsum of his right hand. It has been present for the past 10 days and occurred after he had been pruning rose bushes. On examination, he has a raised ulcerated lesion which bleeds easily on contact. What's your diagnosis? A. Keratoacanthoma, B. Pyogenic granuloma, C. Basal cell carcinoma, D. Squamous cell carcinoma, or E. A melanotic melanoma. D. Pyogenic granuloma.
This is the same question.
Yeah.
Exactly. The same question with the same choices. Squamous cell
Receptors.
carcinoma. Yani last time tell me melanoma here, amelanotic melanoma, squamous cell carcinoma, and the adenocarcinoma. He said squamous cell carcinoma and basal cell carcinoma, and the keratoacanthoma, the same choice, and pyogenic granuloma. And he want to confirm that please anyone will not go for adenocarcinoma or squamous cell carcinoma. Okay, just will go for infected pyogenic granuloma. Okay, I think you will never forget it again. Yes.
Hopefully not.
Hopefully not, yeah. Okay.
That's
Keyword trauma, yes. Dr. Az, keyword trauma, yes, exactly. Okay. You Dr. Nuran? Okay. Dr. Dafer,
Yes.
go.
At 23 years old, lady presented with the itching, bleeding, pigmented lesion on her right thigh. What is the best course of action? Core biopsy, punch biopsy, incisional biopsy, and the excisional biopsy and wide excision. It is a bleeding, pigmented lesion. I said punch biopsy. I don't think so.
It is pigmented lesion. Okay.
It
So
is
what do you think it is?
Melanoma?
Melanoma. So it is
excisional biopsy. D.
Started to bleed.
Yeah.
And start to be itchy. And this is one of the changes from your doubt to convert from normal melanoma or benign melanoma to malignant melanoma, increase in pigmentation, itching, or bleeding, or ulceration, or scattered melanotic spots around it. This is change or malignant transformation. So what you are going to do, you'll go for normal excision biopsy. You will not do white excision except you confirm your diagnosis. So excisional biopsy itself, you already take 1 to 2 millimeter around the normal edge in the normal skin. This is normally for excisional biopsy. And then after you do this, you will, after the histopathology, you will do the classification and the margins and the staging, and according to which you will go for further excision or just enough this excision. Incisional biopsy and punch biopsy and the core biopsy are not allowed in suspicious malignancy. Okay. There is no core. There is no core biopsy, by the way. Punch biopsy in a large ulcer. We take large ulcer. We take a punch biopsy. Okay, incisional biopsy is not allowed for a lesion, small lesion, and this I think no, it's only cheap bleeding, pigmented lesion, in her thigh. Whatever, I think incisional biopsy is not common here. Okay, because you are doubting malignancy, you can do incisional biopsy. Wide excision is not logic to contraindicated without knowing a diagnosis, except for intraoperative frozen section or MOHS, MOHS, micrographic surgery. Okay.
Okay.
So if he didn't mention bleeding or ulceration, the answer will be excision biopsy too?
Excisional, yes. Any melanoma, excision.
Okay.
Any melanoma, we don't take a small piece from the melanoma. Melanoma is removed excisionally. Because if you removed a little piece and it is not malignant, will you leave the other part of it not excisional biopsy you are taking like a wedge. So even you leave it all or take it all, but disturb its shape, it is not logic.
Okay.
Melanoma, excisional biopsy. Okay.
Good.
If he told you it is started to be ulcerated and gives you some features of malignancy and tell you maybe in the leg, very common that tells you the melanoma, malignant melanoma in the leg, and the patient come with inguinal lymphadenopathy. So what is your diagnosis? It will be, I think one of the recalls, the patient comes with inguinal lymphadenopathy with a skin lesion, pigmented skin lesion in the leg for long time. So it will be mostly, or what's your provision diagnosis will be malignant melanoma. Here, you doubt it if you take a lymph node biopsy and make the histopathology and you found it is metastatic malignant melanoma. So you will go for the original lesion by excision biopsy with safety margin. This is the only scenario that you can go for excisional biopsy with safety margin. And I think the safety margin will be, if less than 2 centimeters, it will be 0.5 as well. Okay?
Okay.
This is the only, I think I have read one question about inguinal lymphadenopathy with associated skin pigmented leg skin pigmented lesion for a long time and some change in its color or its shape or start to bleed or itchy. And so, a lymph node biopsy was taken and it is proved malignant melanotic cells or pigmented malignant cells. He will tell you pigmented malignant cells. So the lesion is squamous cell carcinoma and the treatment is excisional biopsy with safety margin. I think this is last question. I think so. Who is Dr. Nuran? Dr. Nuran, biopsy. Go.
An 89-year-old woman presents with long-standing seborrheic warts of her abdominal wall. They have caused troublesome itching. What's the best treatment? A, administration of topical steroids. B, shave excision and cautery. C, excision and primary closure. D, excision and skin graft. Or E, excision biopsy. B, shave excision and cautery.
Exactly. So this is very old woman, 80 to 90, long-standing seborrheic warts or multiple pigmented, itchy, greasy lesions. So just know this definition about seborrheic warts: multiple pigmented, greasy, itchy lesions over the torso. Okay.
Okay.
What's name? Seborrheic warts. What's your management? Shaving excision or shave biopsy. Okay.
Okay.
Okay. Thank you. We finished skin lesions for today, about 1 hour. Thank you. I'll close the recording not to have more time. And if any question, we will ask after. Thank you.
Thank you, Dr. Rami.
Thank you for all. Thank you, Dr. Rami.
Thank you.